Our next speaker is international, well-known international name, Dr. Mahmoud Razavi. He's a director of Center of Clinical Trials and Research at St. Joseph Heart and Vascular Center. He is an author or co-author of over 250 scientific publications, abstracts, and book chapters, and has given over 300 invited lectures over the world. And he will talk about very interesting and actually subject of controversy among vascular community, which is TASC classification. Please, Dr. Mahmoud.
Thank you very much for the kind introduction and the invitation. The congratulations to the peers group. I understand this is the first time that they have that you guys are having an independent, separate meeting from the diagnostic radiology groups, and my congratulations to you. More power to you. Keep it going. My task is to talk about TASC. A couple of disclosures. These are some of the companies I consult for, and the grants and consultations. Most importantly, I am both part of the steering committee and the writing group of TASC. And so my biases will come through, as you all will see in a second, and that's obviously towards TASC. Now, TASC classification and recommendation. Well, let's look at some of the questions. Does TASC matter? Does anyone care? And why is it important to have such classification as we move forward in treatment of peripheral arterial disease? Well, as it is clear to all of you who treat patients with peripheral arterial disease, there are multiple treatment options. Even on the surgical side, there are multiple different conduits and techniques, and on the endovascular side, there's a plethora of different approaches. And we're not clear as to what is the best treatment for any particular patient. And so some of these approaches are sometimes competitive, sometimes complementary, and a lot of times are mutually exclusive. For example, the bypass surgery in the lower extremity, when it goes down, it changes the natural history of disease for the limb. And so if you come back and do endovascular intervention, that outcome is very different if the endovascular is done before surgery. The opposite is also true. So these are all important things to consider. Unfortunately, robust comparative data on the legs are not available. So we really don't know what is the best way to go in many of these patients. And so the question is, how should these patients be treated? And that brings us to the expert panel opinion, and that's where TASC is. For example, some of the most commonly referred to expert panel opinions come from the American Heart Association and the TASC. Now, TASC in that group is the only one that's international. American Heart Association is very American-centric, and there are international people on it, but it is an American organization. TASC is truly international. Now, determinants of therapy, obviously patient's condition, anatomic severity of disease, comorbid conditions, and patient's wishes are all important. And hence, you need disease classification to go into patient's condition and anatomic severity of disease to find out really what is the best way to go in these patients. And this is the only way that we can compare data across various studies to each other. Now, basics of TASC. When recommendations are considered, the clinical presentation is important, obviously, and lesion characteristics in terms of location, length, morphology, things of that sort. These are all considered in coming up with the recommendations. The process of TASC you all are familiar with. Representatives from 16 international societies and health economic experts got together. They've all participated. Extensive review of the literature was done. A document was created, went back to the group, and then we sent it back to the societies, and each one of the professional societies had their own expert panels that reviewed the document and came back to the main group, and it was published between TASC 1 and 2. So it's a thoroughly vetted process. And the recommendations of A, B, and C, you guys are familiar with, so it's not, the slides are cut down the side. I suppose it's okay. And we are all familiar with the classifications. I won't belabor on those. And this is what we have found out over the years in terms of the patency and the TASC classification. Why we know that there's a difference between TASC A and D in terms of patency and outcome. The other ones, there's between B and C and then C and D, there's a significant overlap. I mean, this is what we see with all classifications. If you go to classification of cancer, which is probably the gold standard for classifications, you see the same type of thing, that various classifications of disease, they have significant overlap. So that cannot be a criticism, that a large percentage of patients with A and B or B and C have similar outcomes, therefore classification is not useful. We've seen that elsewhere. Now, who needs TASC? Obviously, the TASC document, well, you may not know that, is the second highest referenced article in the surgical literature, the second highest ever. More than 3,000 references in the literature to TASC, second only to an appendicitis paper, okay? So clearly, it's important. Now, documents, again, clearly, but is it the classification or is it the recommendation that people are following and referencing? But it turns out that when we look at those over 3,000 references, 75% were referenced because of the classification, and only 25% for the recommendations. And that's appropriate. Now, let's look at the recommendations. Risk factor modifications, anti-lipids, antiplatelets, lastazole and exercise for intermittent claudication, and revascularization when needed. These are common to all recommendations everywhere in the world. So these cannot be controversial. So what is controversial about TASC? The controversy about TASC is the method of revascularization. Do we have surgery and do we have endo? But most importantly in TASC-3 process, and I'll describe it to you in a second, it was who decides who gets what that became contentious between the surgical societies on one side and the interventional societies on the other. TASC-2 recommendations for aortoiliac Fempop disease, we all know it, TASC A and B endo, TASC-C probably surgery, TASC-D surgery. Those are the recommendations. The problem with the recommendations from perspective of an interventionalist is in the real world, all patients in Europe and US, when they present to someone who knows how to do endo, they get treated endo, regardless of their specialty and regardless of the TASC classification. In fact, therefore, those recommendations are irrelevant. It doesn't matter what TASC says. It doesn't matter what the aortoiliac disease we have. If we have a Leriche syndrome in my hand, that patient gets endo treated. If my surgical colleagues get it, they may do bypass, they may do endo, depending on their level of comfort. So TASC classification is irrelevant. Recommendations are ignored by all vascular surgeons that I know, and I know a lot because I'm in a surgical group, who know endo. When they're endo trained, they do endo first. And so TASC classifications, irrelevant. TASC-IIb, that brought us to TASC-IIb. So everybody knew that this is irrelevant. We need to redo this. So we started the process of TASC-IIb, where the recommendations were A and B should be endo, C should be endo, preferred, and TASC-D depends on the local expertise. If the local expertise, they can do it endo, do endo. If not, D surgery is preferred. We ran into a significant problem with these recommendations. Initially, surgical societies agreed and signed off on it, including SVS, Society of Vascular Surgery, and the European Society of Vascular Surgery, and the World Federation of Vascular Surgery. They all agreed. Then there was a change in leadership at the Society of Vascular Surgery in the US, in America, and they forced the other vascular surgery societies to go along and counter and oppose this. And they opposed it. And that's where the weaknesses of the TASC process come in. It has become a political document. It is no longer a scientific document because various surgical or interventional societies can push around their influence onto the process. So after an exhaustive 3-year review process by all societies, including surgical societies, SVS and ESVS, SVS threatened to pull out of TASC if TASC-2 was published. This is unprecedented for a professional society to prevent publication of a scientific document, and they did that. And so TASC-2 was pulled from publication. That's why TASC-IIb, that's why you haven't seen it. It was ready in 2007. So we worked with the surgical societies. Again, I'm part of the steering committee of TASC. We worked with the surgical societies, and we said we work on TASC-3. And let's see what the requirements are. We did the same thing. And then the SVS and ESVS were active participants, but withdrew when they could not get their way. What did they want? This is what they wanted. They wanted among their demands greater than 50% surgical representation on all aspects of TASC, including recommendations. And this is a direct quote from SVS. Setting standards across the world for optimal care of this group of patients resides principally with vascular surgeons. This obviously does not fit well with the interventional radiology, interventional cardiology, or angiology circles, which if you look at across the world, in US and Europe, about 50% of those patients are treated, in fact, by non-surgeons. So this did not fit well. And so TASC-3 broke, surgical societies pulled out. And so TASC is now a document of all other, of those 16 specialties, that the societies, as we talked about, 3 left, the other 13 are involved. Now, ideal situation should be that the unmet need in a particular disease is identified, in this case, how do we treat the patients, and then the hypothesis is driven, research and development is done. Based on that, the clinical trials are designed to address those needs and address those questions, and the data is driven, which then drives the societal guidelines, and the societal guidelines should drive practice. That's how it is in cancer. Of most of cancers, this is how it's treated. In peripheral arterial disease, practice is ahead of data. We do stuff that we have no data for. We've all done it. You all know it. Data is ahead of guidelines. The guidelines that are out there are outdated because the data is now proven that that's not true. And NICE from United Kingdom, for example, is completely outdated. And practice politics is ahead of everything else, unfortunately, as I just mentioned it too. So in conclusion, classification of disease is definitely needed for the reasons we talked about. That's, you have to judge what are the best therapies. And standardization of reporting and therapies should be done based on those classifications. TASC process has been the best and has been the only international one so far. And hopefully that will continue. Hopefully we'll be able to get the surgical societies and colleagues back to the table. Thank you.